welcome to the statewide AAU ICSU Critical Care Seminar. We also dub it as SWACS. Today's topic is going to be about pulmonary madness. I'm Dr. Cornelia Selegre, and I'm a lecturer at Macquarie University and also consultant in cardiac anesthesia and intensive care at the Uganda Heart Institute. So we are going to have 4 presenters today, and these presenters have been mentored by Dr. Erasmus Okello, and I will go ahead and request Dr. Erasmus, yes, is sharing his screen. Yes, thank you, Dr. Erasmus. I'll hand it over to you to give us a preamble into this, and then we shall take it away with the first presenter, Dr. Namuviru Sophia. I'll introduce her when the time comes. So thank you so much for logging in, and we hope we shall spend a maximum of 2 hours here. Thank you. Over to you, Dr. Erasmus.
Thank you, Dr. Cornelius. Thanks everyone for logging in, and I essentially, Dr. Cornelius related to this. So 2 years ago, we came to ground to a halt of our good run, particularly with what we dubbed at the time as the AAU Critical Care Rounds. And this time around, we've come back 2 years later. Yes, 2 years and 1.5 months later, we've come back with a new name, that is the statewide anesthesia and critical care seminars. And really that's because everything around us is changing. So welcome back. It's been a while. The goal here is that anesthesia and intensive care so far kind of move hand in hand, and lately we have many disciplines joining the game. We've got emergency medicine, which is basically the start of critical care in any hospital in a way, being part and parcel of our family. And we will be seeing a lot of interactions of these 2 fields, these 3 fields really, that's perioperative medicine, anesthesia, and intensive care. These sessions are brought to us by collaboration of the Intensive Care Society of Uganda and the Anesthesia Society, the Association of Anesthesiologists of Uganda. The idea behind all this is the fact that things are complex now. You know, there's a lot going on in terms of communicable diseases, a lot of non-communicable diseases. We've got a lot of wokeness with so many people not wanting life preventative measures like the anti-vax movement, and certainly there is you who is now having AI around you and getting all the resources to intervene and serve patients better. And definitely the same improvement is happening around the machinery and equipment around in critical care and perioperative medicine and emergency medicine. So the idea is just to be fast up as well. There is a vision behind all this, that is to improve the quality of critical care in Uganda. And there's got 3 prongs to it. That is the aspect of improvement of education and knowledge levels under the education pipeline, which includes work in the institutions, that's of learning, practice, as well as the CPDs for professionals in the field. Then we've got the aspect of infrastructure expansion. The vision the Ministry of Health is to create about 180 ICU beds across the country, 18 hospitals. I couldn't add a picture for one Arthur Kwizera here, but he's been a champion of this, working hand in hand with the AAU, ICSU, and Ministry of Health to find how public health sector can improve its critical care quality and coverage. And then certainly this aspect of national policy alignment, where we are hoping to introduce practice guidelines at some point to harmonize our practices and improve the care of patients, such that if any one of us were ever to land in any hospital, we are kind of sure that we have the bare minimum of the basic care that we need to keep us alive and give us a chance to get better. But today, and through these seminars, our interest educational aspect of it, and our goal is to work on your fitness until you're really fit and strong and prepared to serve patients. And that's what brings us to what we're doing this time around. So in this first episode of the SWACS, we are starting with the lung as a continuation from the previous topics we had under the AAU ICSU seminars. This time we're starting with the lung, and the idea is to handle pulmonary madness, so let's say aspects of lung medicine in critical care medicine. And our topic today, our theme today is to do with the physiology of the lung, that is the lung in motion. Essentially, our goal is to enrich ourselves with the aspects of physiology of the lung in health, as well as under mechanical ventilation, just to give us a clue of what we can work on to improve patients' outcomes, as well as how our main tool in ICU for respiratory support is a ventilator, how it could also harm patients. So just starting with the basic physiological aspects, and ultimately we will keep growing and getting more detailed and more thorough with everything as we go ahead. And hopefully some topics will resonate with us because we see these things every day practices. So first, we shall have a number of presenters today. There are the 4 presenters. This is Dr. Sophia. She is a resident at the department for anesthesia, and she'll be discussing respiratory system basics. And then later on, we shall have another presenter, that is Dr. Shaif, who will be taking us through ventilation profession relations. Dr. Kemigisha is an emergency physician, who will take us through mechanics of breathing. And finally, we shall hear from Dr. Fred Nsereko, who will take us through the respiratory support and physiology of mechanical ventilation. These talks will definitely be time-bound, and we hope that the presenter can cover the time, their talks within a certain period of time. And the rules from the rest of us are really just to make sure we give them the due audience by avoiding open mics, unnecessarily open mics, ask questions at the end of the talk, and particularly where possible, put your questions on the chat so that we don't interfere so much with the conversation going on. So over to you, Dr. Cornelius, for the rest of the introductions. Thank you.
All right, thank you. I think the introductions have been made, so I will just inform the audience that all your mics have been muted, and you will not be able to unmute them until the Q&A starts. Only those who have co-host to unmute themselves. So Dr. Sophia, please share your slides and start away with the presentation. Since we have 2 hours, we shall give you approximately 20 minutes max to be able to complete your slides. Thank you.
Okay, good evening. Good evening, am I audible?
Good evening, we can hear you loud and clear. You can put your slides in the presenter mode. Thank you.
Okay. So I'm going to talk about just a brief, I'm going to have a brief talk about just the anatomy, physiology of the respiratory system, and I'll just start right away. So the content for the talk, we're going to talk about airways, the blood-gas interface, the oxygen cascade, the gaseous exchange, and then how this oxygen gets to the different tissues in the body. So we know the primary role of the lungs is gaseous exchange. So much as it has other roles like the metabolic roles and the protective role, today we are going to focus mainly on the aspect of gaseous exchange, and we're going to look at how it has adapted to to do its role well. Yeah. So this is a sort of a structure that was designed by Weibo after he sat down and dissected the respiratory system and tried to measure, analyze, and sort of come up with a pictorial, a picture of what the airways look like. Yeah. So the airway we know starts from the nose, that's how we're going to breathe in the air. So when we breathe in, air gets humidified and then comes in via the pharynx and then into the trachea and till it reaches the alveoli. So for the trachea and the bronchi, they're made up of cartilages, and then we continue where they divide again into the different lobes, and then also those divide into the different bronchioles and then into the terminal bronchioles. Now, up till the terminal bronchioles, we do not have any alveoli. All this is just sort of to conduct the air and till it reaches the gaseous exchange part. Yeah. So after the terminal bronchioles, we have respiratory bronchioles, and that's where we are going to start seeing alveoli. Yeah. Then as we proceed down, more alveoli, and then till we reach the alveolar sacs. Yeah. So from the trachea, the bronchi, we have cartilage, and then we have smooth muscle coming into play. Now, the smooth muscle also has receptors, where we have the beta-2 adrenergic, and then we also have the muscarinic receptors. So if these are stimulated, we have bronchodilation in the case of the beta-2 adrenergic receptors, yeah? So we can continue to how much is in which part. So we have from the trachea to the terminal bronchioles, which we call the conducting zone, having about 150 mils, yeah? And then we have the volume of air that is in the alveolar region being as much as like 2.5 to 3 liters. So you see how that difference in the volumes. So this brings us to the blood-gas barrier, yeah? Or now, like when we reach the alveoli, what next? So in the alveoli, we have different types of cells, where we have the type 1 alveolar cells. These are the ones that carry out the gaseous exchange. Then we have the type 2 cells, which have what? Let me get a pointer. Yeah, okay. Then we have the type 2 cells, which are responsible for producing surfactant. And surfactant plays a key role because it reduces surface tension and prevents these alveoli from collapsing, yeah? So on this diagram, important to note also is this, the pores of Kohn, yeah? So these are just spaces between the alveoli that at first were thought to be pathologic, but with time they've been noted to be a normal occurrence in the alveoli. And we'll talk about them more as we continue, yeah? So the blood-gas barrier is basically this. So we've just sort of enlarged this a little bit. And we have the type 1 cell on one side, the alveolar cell on one side. Then that's with its epithelium. Then we have the basement membrane, and then we have the capillary endothelium. And that's where, that's what oxygen has to pass through. Like, so if you notice, it's a very small membrane. So it's about 0.3 microns, and it has surfactant onto it. So in total, we have about 500 million alveoli, giving us an area of about 50 to 100 meters squared, yeah? So blood supply, we are going to talk more about it, but important to note, the pulmonary arteries are going to transition still to the capillaries and then to the pulmonary veins. But in the pulmonary circulation, you're going to note that the arteries they are not as muscular as they are in other parts of the body. They actually almost look like veins and might be different, and it might be difficult to differentiate them, yeah, under like microscopy. Yeah, and it's a low vascular system. So there are really low pressures in the lungs. So we've talked about the pores of Kohn. They're usually bounded by the type 2 cells, and they are filled with surfactant. Their function has been to allow just collateral ventilation between the alveoli. So collateral in such a way that it doesn't pass through this hole, through the alveoli and stuff. There's studied sort of transfer of nutrients between adjacent alveoli cells. So the blood supply, we have two major supplies. We have the bronchial supply from the bronchial circulation and the pulmonary circulation. So for bronchial circulation, these are from the bronchial arteries, and this is going to supply mostly the conductive airway. Yeah, and after, blood that comes from this circulation is going to just come and drain into the pulmonary venous circulation. Now, important to note that in the pulmonary circulation, much as it's draining into the pulmonary venous circulation, the pulmonary venous circulation is actually the blood that is oxygenated. Yeah, so unlike other parts of the body, in the airway, the pulmonary veins are the oxygen, like they're carrying oxygenated blood. So it creates sort of a shunt, and that the next person who is going to talk is going to share more light about that. So we continue to pulmonary circulation, and for pulmonary circulation, we're going to have the venous blood coming from the right ventricle via the pulmonary arteries. These pulmonary arteries are going to move more intralobar, like in the center of these alveoli, and then get oxygenated, then transition into the pulmonary veins. So how can we tell how much oxygen is in the alveoli? Yeah, we can get that from what we call the alveolar gas equation. So for the alveolar gas equation, basically, you can get all, it's this equation right here, yeah? And it's to get the partial pressure like of the alveolar oxygen, you're going to get the partial pressure of the inspired oxygen. And then you subtract it from this P, the partial pressure of arterial carbon dioxide out of this respiratory quotient. So this partial pressure of carbon dioxide you can get that from the ABG. And then this respiratory quotient varies on diet. It's basically how much carbon dioxide you're going to produce for every oxygen. Yeah, so depending on the diet you're having, this respiratory quotient differs. So for people who have like sort of a balanced diet, the respiratory quotient is about 0.8. Yeah. Yeah, so this is this. So for this partial pressure of inspired oxygen, you're basically going to get the barometric pressure. Yeah, this is the pressure, like for example, at sea level, it's 760 minus the partial pressure of water, because we know if we breathe in the oxygen, we are going to, by the time that, sorry, when we breathe in air, by the time it reaches the trachea, it is concentrated with, it's saturated with water vapor. So we have, and that water vapor, that means reduces the partial pressure of that inspired oxygen. So you're going to get the barometric pressure minus the partial pressure of water, which is about 47. Then you multiply it by the FiO2. So FiO2 is still like fraction of inspired oxygen. So still we know room air, that's about 21%, yeah? So you can try, if you put in normal values for this, you'll find out that alveolar oxygen is about 100 millimeters of mercury. So this, once again, how we've been talking, we've talked about part of it. So it's the oxygen cascade, yeah? How it comes from the atmosphere down to the tissues, yeah? So we've talked about from atmosphere till the alveoli, right? So when it reaches the alveoli, it diffuses. After it diffuses, you're going to have a slight reduction in the partial pressures in the arteria versus the alveoli, yeah? But in disease cases, you might find out that actually this partial pressure here is a bit more than this partial pressure here, yeah? And the next person will highlight more on that. I will not preempt them. Yeah, and then we can continue. So how does the air reach the alveoli? Yeah. So how it's going to move? The commonest way it's going to move in the conducting zone is by convection, just simple flow. Yeah, from outside into the trachea down into the these terminal bronchioles. Now, when it reaches here, the velocity will have reduced, because if you look at, okay, this area here where we are putting where the air is coming, as opposed to this downer part, there is a steep sort of rise in the surface area. Like it has to go, remember, it's the same amount of air you're trying to get into all these places. So at first here, just a simple convection, we have our air coming into the airway. But once it reaches here, there's sort of like, there are many branching. The branching is too much, so the surface area is increasing, and simple convection is no longer sufficient enough to move this air. So you're going to find that from that terminal bronchioles, once it's coming to the respiratory bronchioles, it's now going to move by diffusion, like just moving from where it's in high partial pressures to low partial pressures. Yeah. So this also explains, like, for example, these miners, when they get in that dust, it's going to move at first freely very well. But once it reaches this transitional area here, yeah, because dust is not easily diffused, you're going to find that it's going to barely come and reach the alveoli. So you'll find that most of them will be deposited in these areas here. So what happens when it reaches the alveoli? Still, we're going to just have it. We're going to have gaseous exchange occurring. And gaseous exchange follows fixed law of diffusion, like just diffusion. And fixed law of diffusion is basically rate of transfer is directly proportional to tissue area and inversely proportional to the tissue thickness. So this is it. So for the gas that will be diffused, yeah, there is a direct proportion to the area, the surface area of the diffusing membrane. And then we have a diffusion constant, and then we have a difference in this the partial pressures of the gas between the diffusing membrane, yeah, or where it's diffusing, and inversely proportional to the thickness. So for the diffusion constant, it's also directly proportional to the solubility and inversely proportional to the molecular weight of the gas. Yeah. So this brings us to our next part, like what we call diffusion versus perfusion limited in gaseous exchange. So we know the red blood cell moves through a capillary for about 0.75 seconds. Yeah. And usually it's going to get saturated in the first 0.25 seconds. That's normal. And if this is normal like that, we're going to find out that there are gases that are diffusion limited and those that are perfusion limited. So for carbon monoxide, because of its higher affinity for hemoglobin, yeah, once it comes, the capillary is one side, and we have the carbon monoxide, let's say in the alveolar. Because it binds tightly to the hemoglobin. Whatever carbon monoxide diffuses into the capillary is going to be bound by the hemoglobin. So there is going to maintain that there's going to always be that difference in the partial pressure. So there is more of, like, it's how fast it can diffuse. So by the time the red blood, okay, by the time that blood, if we had, like, it's like diffusion is the problem, because there is the partial pressure, or like that everything is sufficient for diffusion to occur. But the reason we are not getting saturated is because it is sort of slow, like it's the diffusion that is the issue. Now, for nitrous oxide does not bind to hemoglobin. However, it is highly soluble. So when the same blood comes into the into the capillaries, and as soon as we start, as soon as the blood passes by, the nitrous oxide will rapidly, dissolve into the blood and create like, it's going to reach an equilibrium very fast because it's not being taken out. So in that case, you need even more blood because this one is already saturated with nitrous oxide. Hope I explained that. So what of oxygen? So for oxygen, we are going to say it's mostly perfusion limited. Why? By the time the red blood cell usually comes back into the lungs, it sort of has already some oxygen, So because it's not empty, like by the time it reaches a third of the capillary, we're going to find that that blood is already saturated with oxygen, and like no more oxygen can be taken up by the blood. And that is why we're going to call it perfusion limited. However, in some disease conditions where we have thickening of the blood gas barrier, you'll find that the red blood cell will reach the end of the capillary when it can still take up more oxygen, but because of the increased thickness, oxygen becomes diffusion limited. So after oxygen is taken up into the blood, it's going to be taken up in mainly two forms: bound to hemoglobin, or actually dissolved in plasma. That takes about just 2%. So this equation is just basically how much of this oxygen we take up, is going to be delivered to the tissues. And it's going to be mainly dependent on the cardiac output times sort of like the hemoglobin bound oxygen plus the dissolved oxygen. So cardiac output is here, and then we have this. This number here is the Hafner's constant, and it's basically just the maximal oxygen carrying capacity of blood. So some books say 1.34, but some also say 1.39. That varies. There are many other factors that vary. And then this hemoglobin is also dependent on what the patient has. And then the saturation of oxygen, still, like, you can get this. And then this partial pressure of oxygen in the arterial, this is like the dissolved one plus and times the solubility constant. So all this in total, you can get the delivered oxygen to the tissues per minute. So take home, the respiratory system is highly specialized for its role for gaseous exchange, and it has very many functions. And it's not only gaseous exchange, but gaseous exchange is the main function. And then basically that's it. Any questions? Back to Dr. Cornell. Those are my references.
All right, thank you very much, Sophia. Are there any questions? In case there are any questions, the idea was we post them in the chat. I don't see any question in the chat, so perhaps let me launch a poll so that we can fill it in. just let me know if you can see it. In case you can't see it, we shall take about maybe a minute or two to just respond to the poll. Can you see the poll, Sophia?
Yes, we can.
Okay, just please respond to the poll. This is based on the questions, well, based on the discussion from Sophia. Just try to answer those questions, and then we shall have Sophia take us through them, and then we shall go to the next presenter. This is to simply help us to create some correlates between clinical correlates between the discussions from these presenters to the bedside in terms of patients and the care we give them. So I'll just stop talking now and give you about 2 minutes. All right, so the poll has been closed. I will now share the results. Okay, so you should be able to see the results of the poll. So Dr. Sophia, the first question here is, we have a 60-year-old patient who is being evaluated for dyspnea. Pulmonary function tests suggest significant small airway disease. Considering the Weibull model of airways, which generation of airways is most likely to be affected in this condition?
Doctor, it's going to be the generation 17 to 19.
Okay.
I explain again, or
why do you say generation 17 to 19?
okay. So when we're seeing the convection, like the airway flow through the alveoli, we note that during that transition from like the conducting airways to the respiratory side of it, we are going to have sort of a reduction in velocity of that gas, and so we most that's like where you're going to find most of the deposits, like those are the places that are mainly going to be affected.
Okay. So what condition? So this patient seems to have a condition that is affecting the pulmonary function tests. And if you have smaller airway disease, some of the most likely area that's going to be is in the conducting zone. So which conducting zone do you think this would be? So maybe what I'm trying to drive at is this is more likely going to be generation 5 to 16. And that is where you mostly are going to have small airway disease, primarily affecting the bronchioles. And that's where you have a little bit more smooth muscle. From generation 17, you probably have a lot more gaseous exchange at that point and less smooth muscle. So you're not likely to get significant effect on the airway resistance. So if in case you get inflammation in the between 5 to 16, like we see it in COPD patients, then you're most likely going to present with changes within your spirometry. Okay, question 2. You have a 45-year-old male who is admitted to the ICU, acute respiratory distress syndrome. A CT scan shows diffuse alveolar damage that we already see. Which of the following statements about alveoli is correct and clinically relevant in this context? So, Sophia, do you want to take us through what you think would be the most correct answer here?
Surfactant production in the alveoli reduces surface tension.
Indeed. So that is usually the hallmark of ARDS. Of course, I'm sure someone is at the back of their mind saying, why don't we then give a surfactant to ARDS patients? And I think that will come much later as we discuss all this as we have these seminars. All right, so surfactant is, like you said, is produced by type 2 alveolar cells, and the major function of surfactant is to reduce surface tension. In other words, reduces lung collapse and alveolar collapse that is often seen in ARDS. And question number 3, we have a 55-year-old with COPD, is noted to have hypoxemia refractory to supplemental oxygen. Part of his hypoxemia is attributed to the physiological shunt created by the bronchial artery circulation. Which of the following best explains this shunt fraction? Which of these, Sophia, do you think best explains it?
The bronchial arteries drain directly into the pulmonary veins, introducing deoxygenated blood into the systemic circulation.
Yes. All right. I think that one you mentioned as well. And then the final simple question, which gas diffuses faster, oxygen or carbon dioxide?
Carbon dioxide.
Do you want to explain to the audience why?
It has to do with the molecular weight.
Mm-hmm. All right, maybe one of your seniors will give us that explanation. It's quite interesting, but yes, it has to do with the molecular weight, although you have to elaborate more on what it has to do with the molecular weight. Okay, so thank you, Sophia. We shall go ahead to the next presenter, and that is Dr. Semakula Shaif. Dr. Semakula Shaif, please share your slides and we proceed. Dr. Semakula Shaif is currently, I think, a third-year resident in the Department of Anesthesia and Emergency Medicine, and he's going to take us through. I don't know if he's online. I don't see him sharing. Oh, yes, I see him now. Shaif, do you mind sharing your slides, please? Okay, so Sharif as he shares the slides, he's going to talk about ventilation perfusion relationships, and hopefully he will tell us, add more meat to the bones on why oxygen may diffuse faster. And in case he can't, he can always escalate the situation to the next person. All right, Dr. Semakula, the floor is yours. Please go ahead. Good evening. We can hear you, Semakula. Please go ahead.
Yeah, sorry about that. Yeah, so Safe Samakula, I'm talking about mostly the ventilation perfusion relationships and how they affect how they cause hypoxia or hypoxemia. So we shall talk about the definition. The previous presenter talked about the AA oxygen gradient, and then just the mechanisms of hypoxia. So hypoxia, by definition, the decreased partial pressure of oxygen in blood, whereas hypoxemia is decreased partial pressure of oxygen in blood, while hypoxia is defined as reduced level of tissue oxygenation. And this can be either due to a defective delivery or a defective utilization of oxygen by the tissues. And both hypoxia and hypoxemia do not always coexist. For example, you could have a patient having hypoxemia, but without hypoxia. That is when they've compensated. For example, you have an increase in hemoglobin level or an increase in cardiac output coming into to compensate for the hypoxemia. Then similarly, you can have hypoxia without hypoxemia. For example, that occurs in cyanide poisoning, where you have enough oxygen, but then the cells are not able to utilize the oxygen. Then Sophia has talked about the AA gradient. So I'll just go read, and usually in a young person, usually your AA gradient is less than 10, but this value increases with age, and aging. This is because aging induces a decrease in the PaO2 level through a rise in the VQ mismatch, and after 70 years of age, your VQ mismatch, your AA gradient will increase by 0.43 per year. And then talking about the mechanisms, there are various mechanisms of hypoxemia, and these are the most common being the VQ, the ventilation perfusion mismatch, which I'm most likely to talk about. And then it could be a right to left shunt, could be diffusion impairment, could be hypoventilation, or low inspired PaO2. So in the ventilation perfusion mismatch, this is the most common cause of hypoxemia. Normal VQ mismatch usually stands at 0.6, 0.8, with some sources quoting about 0.6 to 0.9. So ventilation, perfusion, and VQ mismatch are not usually uniformly spread out in the human lung because you have regional heterogeneities. And this is caused usually because of gravity and then a variable subatmospheric intrapleural pressures. And what happens is that ventilation and perfusion are highest. Ventilation and perfusion is higher at the base and lower at the apex of the lung. But then the ratio takes the other route where it's highest at the apex and then lower at the base. So the ratio is low at the base. This is because the rise in perfusion as compared to ventilation is higher. And then it's highest at the apex because the fall in perfusion because of gravity is higher compared to the fall in ventilation at the apex. So there's an important compensatory mechanism that occurs due to hypoxemia, particularly when it's chronic. And but it can also occur in an acute phase where the human body will restrict perfusion to areas of the lung with reduced ventilation, and this is also this is known as hypoxemic pulmonary vasoconstriction, and it's unique to the pulmonary vasculature. So, and by reducing perfusion to these areas, to areas with reduced ventilation, blood will be diverted to the well-oxygenated lung regions. And then the basic goal is to maintain a matching between ventilation and perfusion. The pulmonary vasculature are selective of hypoxia, and this is because they have oxygen-sensitive potassium channels. And what happens is that when you become hypoxic, there's an inhibition of these oxygen-sensitive potassium channels, and this sets off a process that induces hypoxic pulmonary vasoconstriction. So, an accumulation of intracellular potassium due to inhibition of the channels causes a rapid depolarization of the cells, and then and which later causes a opening up of the voltage-gated L-type calcium channels, and then an influx of calcium into the smooth muscle will cause contraction, and then you have the pulmonary vasculature going into vasoconstriction. So on the other hand, if you have a raised PaO2, this causes the smooth muscles in the pulmonary vasculature to relax, and this reduces vascular resistance and facilitates an increased blood flow to the well-oxygenated alveoli, thus improving oxygenation. So what are the effects of VQ inequalities on overall gas exchange? So if you have a VQ ratio of 0, also known as a pulmonary shunt, you'll have no ventilation, but then you'll have a perfusion remaining normal. This is seen in alveolar flooding, usually seen in pneumonia or ARDS. Then you could see this in complete obstruction of the airway. You could see this in extrinsic compression of alveoli, and also from possibly like a pneumothorax. Then you could also have a low VQ ratio or less than 1. So this is where you have low ventilation relative to perfusion. and this can be seen in impaired in partial or incomplete obstruction of the airways. Causes can include low compliance seen from pulmonary fibrosis, lack of surfactant, or like in lack of surfactant. Then you could also have a VQ ratio equal to infinity, which is also known as a dead space, where you have no perfusion, but then ventilation remains normal. This could occur in a situation of a pulmonary embolism, emphysema, or bronchiectasis. Then you could also have a VQ ratio of more than 1, where you have a low perfusion relative to ventilation. This can be seen in hypertensive states or partial obstruction of the pulmonary vessels, for example, by a submassive pulmonary embolism. So when you look at this diagram, on the left you have a ventilation. I think the next presenter will talk about the lung zones, but then just to throw more light onto this. So at the apexes, you have at the side of ventilation, you have intrapleural pressures being more negative with a greater transmural pressure gradient. And alveoli at the apexes are seen to be larger, and which means they are less compliant, and then you will have less ventilation. But then at the base, you have intrapleural pressures being less negative, smaller transmural pressure gradient, and then alveoli are smaller, which means they'll be more compliant and will allow for more ventilation. Then on the other side of perfusion, at the apexes, you have lower intravascular pressures, you have less recruitment and distension. So you have a very high resistance in the pulmonary vasculature because of course the distension, the very large distension in the alveoli, and then you which compromises blood flow, so you'll have less blood flow. Then at the base, you have greater vascular pressures, you have more recruitment and more distension in the blood vessels, and you also have because the alveoli are smaller, you have less resistance to blood flow and then greater blood flow. So then what are the effects of posture on VQ ratio? So in standing or sitting position, pressure is usually not uniform in all parts of the lungs. So while you're standing, the upper parts of the body almost have no blood flow. And usually will have a ratio of greater than or equal to 3 or close to 3. While in the lower lung parts, there'll be more blood flow. So the ratio will be decreased close to about 0.6. Yeah, so the characteristic features of VQ mismatch. So usually hypoxia due to a VQ mismatch can easily be corrected with supplemental oxygen, and usually gives you a widened AA oxygen gradient. And then another mechanism of hypoxia is the shunt, the right to left shunt. This is where blood is moves from the right side of the body, right side of the heart, to the left side without taking part in gaseous exchange. They could either be intrapulmonary shunts or intracardiac shunts. Intrapulmonary, seen as bronchial veins draining straight into the pulmonary veins, like you've seen, or intracardiac shunts, such as the coronary or the Sebacean veins draining into the left atrium, or it could be a VST or NST. And a shunt is an extreme degree of is the extreme degree of a VQ mismatch that can occur. So poor response to oxygen is a feature that differentiates usually a shunt from other mechanisms of hypoxemia. And failure to improve the PaO2 by oxygen delivery is due to inability of the oxygen to improve the alveolar oxygen in unventilated lung units. So in the for the shunt, you'll have an AA gradient that is elevated, and you'll have poor response to oxygen therapy, and the PCO2 might be normal. And we've seen the causes of shunts could be a pneumonia, could be pulmonary edema, could occur in ARDS or AV malformations. Then the other mechanism of hypoxemia is diffusion limitation. So this occurs when oxygen transport across the alveolar capillary membrane is impaired, and usually diffusion limitation may occur because there is decreased surface area available for diffusion, for example, in pulmonary edema or maybe fibrosis, and since both oxygen and carbon dioxide, are transported across the same membrane, you'd expect to have hypoxemia plus hypercapnia, but that's not usually the case. And hypercapnia is usually is uncommon due to in cases where you have diffusion limitation. This is because CO2 is 20 times more soluble in water than oxygen, and thus it's less likely to be affected by diffusion limitation. This means in a very short time, you'll have a CO2 diffusing out while oxygen is still struggling. Then another reason would be that could be that hypoxemic mediated stimulation of the ventilation would lead to hyperventilation, and therefore you have a CO2 washout. And one other important characteristic of also diffusion limitation is that the hypoxia usually worsens with exercise. So characteristics of hypoxia due to diffusion limitation, you have an AA gradient that is elevated. You'll have hypoxemia, which shows good response to oxygen therapy, and you'll have a PaO2, a PaCO2, which is usually normal. Causes as said above, fibrosis, edema, and then the other mechanism of hypoxia is hypoventilation, where you have the oxygen molecules reaching the alveoli due to due to decreased ventilation. So the characteristic would be a normal AA gradient and PaO2, which normalize on supplementing oxygen. Then you also have an increased PCO2. Causes include decreased respiratory drive from an opioid, from a stroke, from a neuromuscular weakness, such as in Guillain-Barré syndrome, chest wall abnormalities such as kyphoscoliosis or flare chest, could be in COPD. Then and lastly, the last mechanism of hypoxia is low inspired oxygen, where you have few oxygen molecules entering the lung with respiration. It's characteristically, it has a normal AA gradient, and you have PaO2 that normalizes with supplemental oxygen. This is usually seen in areas of low atmospheric pressure, such as high altitude, such as high altitude, where you have an FiO2 that is usually less than 0.21. And other types of hypoxia could be ischemic hypoxia, where you have insufficient blood flow to the tissues. This is also called stagnant hypoxia. Could be due to a low cardiac output. Then anemic hypoxia. Anemic hypoxia is where you have insufficient oxygen carrying capacity. For example, in cases of severe blood loss or abnormal hemoglobin, such as COH, that is carbon monoxide, carboxyhemoglobin, and then methemoglobin. Then you could also have a cytotoxic, cytopathic hypoxia, where cells cannot use the oxygen as seen in cyanide poisoning. Then I was also asked to talk about proning and how it affects the VQ relationship. So proning is a therapeutic intervention usually used in management of hypoxic respiratory failure, like as seen in ARDS. What does proning do? Usually, proning improves VQ matching by distributing blood to the better ventilated posterior lung units. In a spine, in spine position, gravity usually pulls blood in the dependent posterior lungs, which are usually which are often collapsed. So reduced lung proning also reduces lung compression because in prone you'll have the heart and then the abdominal organs exert less pressure on the posterior lungs, and this will allow them to expand more effectively. Then proning also enhances alveolar recruitment because collapsed alveoli in the dorsal lung regions usually in proning they reopen, and this improves oxygenation and improves lung compliance. That is the end of the talk, and thank you for listening.
All right, thank you very much, Semakula. Okay, so just reading something. Okay, so are there any questions for Dr. Semakula? I do not see any questions in the chat, unfortunately. I hope that whatever the presenters are giving us is actually very satisfactory to the audience. But since I don't see any questions, please remember you cannot unmute. In case you want to speak, you will have to put your hand up and then you'll be given permission to ask a question. So feel free to do that. All right, since there are no questions, I'm going to launch the next poll, and then we can respond to it. Okay, here is the poll. Please feel free to respond to this poll. Again, it's not to test your knowledge. It's to simply try and focus the talks to clinical application. So there are 4 questions, and they're all based on the talk that Dr. Semakula has given. And at the end of this, we shall request Dr. Semakula to give us his take on the questions. So we shall take about two minutes. Okay, 10 seconds left, and I close the poll. We have at least 25% of the audience having responded. So closing the poll in 3, 2, 1. All right. The poll has been closed. So let us go to the first question. Dr. Semakula, I hope you can see the questions there. I'm sharing them now. So as individuals age, ventilation perfusion mismatch tends to increase. Which of the following best explains this physiological change? Dr. Semakula, your take? Hello? Dr. Semakula, can you hear me?
Yes, Doctor.
Yes, the question is before you. Your take, or the audience, a big percentage of the audience has selected C, which is option 3. What's your take? Dr. Semakula?
I would go with A. I went with A.
Okay, what's your rationale?
As they age, usually you get as you age, you have reduced elasticity, and you have your physiology tending more towards the closing capacity. So I would expect them to have reduced ventilation in the lower zones and more valvular collapse.
that also sounds like option 3 would be correct. So you're right, indeed. With aging, the elastic recoil of the lungs tends to decrease, and of course that affects the closing capacity. That's basically the lung volume at which your small airways start to close. And as we grow old, the closing capacity tends to increase, I think, by about 10 to 20% every decade. And so this causes the more dependent regions of the lung, which is the bases, to usually close earlier during the expiration phase. Yeah, so that tends to be, that's more or less the answer for this patient, for this particular scenario. So option 3 is actually more accurate. All right, and then question 2 is about the following, which of the following mechanisms is the commonest?
Dr. Cornell,
Yes, please.
Dr. Cornell,
Yeah.
you said option 3 is most correct.
Yes. Option 3 is most correct. So it is not that we have reduced ventilation in the bases. Actually, the issue is more to do with the decreased elastic recoil, and that leads to actually poorly to more ventilation. The VQ in that case is higher, so the lung in those bases gets more volume, but doesn't have as much supply as one would want. So that's what tends to lead to that as we grow old.
Yeah.
All right. So question 2 is commonest mechanism of hypoxemia. Which one is it? The audience picked VQ mismatch. You agree?
Yes.
Okay. And then now, what is the primary mechanism of hypoxemia in pulmonary embolism? The options are 4. The audience majority picked increased dead space ventilation.
Yeah, increased dead space ventilation.
Right. And then which of the following mechanisms of hypoxemia are most commonly does not respond to oxygen administration? The audience, 58% selected. Okay, good. All right, I will stop sharing and then.
Dr. Cornelius?
Yes, Erasmus, please go ahead.
Sorry, so regarding question 3, I just want to differ from the audience. We generally believed that it's, when you have a PE, you're going to get dead space ventilation. But commonly because of the effective, hypoxic pulmonary vasoconstriction and hypoxic pulmonary bronchoconstriction, most of these patients suffer massive PEs, end up diverting blood flow to other parts of the lung. And this is in a situation where also the PE has compromised the perfusion, that's the Q. So there's going to actually be quite a gross VQ mismatch in this patient. So it turns out that the main mechanism of hypoxemia in massive PE is actually a VQ mismatch rather than dead space, much as the physiological disorder at the level of the clot itself would be ideally dead space.
Yeah, I think the argument would be whether it's a massive PE, or if it is a submassive, or just the regular PE patients who come in with hypoxemia and it's not massive. So I think the effect of the mechanism, or one, I do believe it's very erroneous for us to assume only one mechanism may exist. And then number 2, with regards to PE, it depends on the degree of the obstruction, and which mechanism at that point will be more pronounced than the other. So the question was not very elaborate with regards to how massive this PE is. So that is why, generally speaking, yes, I agree with you with the hypoxic pulmonary vasoconstriction. But I think there is an element of truth that is dead space, despite the reflexes. The reflexes are not absolute and complete in averting the effect of the dead space, especially if it's not a a massive PE. So I think that's something for us to sort of think about in terms of the spectrum of that PE. I don't know what you think, Dr. Rasmus, about that.
Yeah, I agree totally. Especially with the fact that, in terms of trying to learn this stuff, we try to take it in fractions and try to understand one mechanism versus the other. But when it comes to pathology itself, for sure, there's always an interaction, and all disease manifestations are merely an amalgam of the different ones. Sure.
Okay, thank you for that submission. All right, Dr. Kisha, I will request you to share your slides. Her real name is Kemigisha Asemwe, but she tends to go by an alias, which we are more familiar with. So I will request you to, oh, sorry, let me stop sharing my results and then hand over to you, Dr. Kemigisha, to, is she online? I don't see her. Okay, let me give you co-host. All right, please go ahead and share your slides and take us through the mechanics of breathing. Hello, Dr. Kemigisha? Dr. Kemigisha, maybe to introduce her a little bit as she prepares, is an emergency medicine physician with a predilection to intensive care medicine. And she's going to give us a talk about mechanics of breathing. So take it away, Kemigisha. Thank you.
Good evening, everyone. Thank you, Dr. Cornelius, for the introduction. So I'm going to talk about mechanics of breathing. I'll try and make it as brief as possible, as simple as possible. So basically, when we're talking about mechanics of breathing, we just basically want to know the physics concerned with the different forces, motions, and basically your pressure, your volume in relation to breathing. And breathing basically just means movement of air in and out of your lungs. So my outline, I'll just basically have a brief introduction, talk about the mechanics of breathing. We'll go into control of breathing, lung compliance, and spirometry. So this is potentially what your chest cavity looks like. And you have your thoracic wall, your lung, and like Dr. Sophia had talked about the different generations of the respiratory system, which I'm definitely not going to. So sorry about that. I have a bit of noise. Thank you. So in the chest cavity, you have your inside where your alveoli are, this area, which is basically the intrapulmonary area, and then between outside your lung, you have the pleura, where you have the parietal, the viscera, and the parietal, and just in between there's a thin layer which would form the pleural cavity, and then you have your thoracic wall. So the pressures in your lung are basically your intrapulmonary pressures and are usually equal to your atmospheric pressures, where your atmospheric pressure is 760, and your intrapulmonary pressures, okay, would say zero at rest. And in between in your pleural cavity, your intrapleural pressures are basically negative 4 millimeters of mercury. And the reason as to why you have a decrease in pressure in the pleural cavity is due to different forces of the elasticity of the lung that is trying to pull, different forces that are trying to pull the lung to try and recall it, and surface tension of your lung tissue, but also elasticity of the chest wall. So this ends up decreasing your those different forces end up decreasing your pressure to about -4. And we'll go on to see why this is important. So we all know that once you breathe in, okay, we all know that the most important muscle for breathing is the diaphragm, which controls about 75% of our intrathoracic volume during quiet inspiration. And it basically has three major portions, where you have the costal portion that is connected to your rib region, the rib cage, and the crural portion that is connected to your vertebral region, and also the central tendon that connects both. So your major muscles are, for inspiration, are your diaphragm, and your external intercostal muscles. So during we know the principle of Boyle's law that says at a constant temperature, you have your volume being inversely proportional to your pressure. So what happens when you contract? During inspiration, the diaphragm will move up, will move downwards, and your ribs will be pulled by external intercostal muscles upwards and form like a bucket movement in order to increase the volume in the lung. And that increase in volume will decrease your pressures, and that will allow, we all know, pressure will move from a place of high pressures to places of low pressures. So you have air getting into your lung and it will fill. So during expiration, which is a passive process, the reverse occurs. You have your volume decreasing, and once your volume decreases, as your diaphragm moves up and your internal intercostal muscles move out. Yeah, move in, your volume reduces, your pressures increase, and then you're able to expel. So basically, that's what we mean by expiration. So this is just a summary graph that will just show us during inspiration in the alveoli. Remember, your pressures are at 0. They're same as your atmospheric pressures. So as you inspire, during inspiration, your pressures will go down from 0 to about -1, -3, and then midway you will have your pressures coming back up as your diaphragm gets back to its normal volume during expiration, and then you finally have then you have your pressures going up midway, and then you expire. Then your intrapleural pressures will come from, we talked about them being around -3, -4, -2. So during inspiration, you will, due to the fact that your volume you're contracting, due to the fact that you're expanding, the volume is expanding, your volume increases, your pressures drop further negative, and then during expiration, your pressures will go back up. This dotted line is basically the path that would take if there was less resistance due to your air, due to tissue and different muscles in your pulmonary system. So basically, this is just a summary of what I have just said. You inspire, pressures, your diaphragm goes up, increases volume, and then pressure reduces, and during expiration, your diaphragm and your intercostal muscles relax, return to position, reducing the volume in the lungs, and then you end up increasing pressures and you end up expiring, which is basically a passive process. So moving to control of breathing. So we know the control center is usually in the medulla, but we know in the pons, we have a center, the pneumotaxic center. Usually this is responsible for fine respiration. It basically inhibits inspiration. It allows that transition from inspiration to expiration. So when patients, it basically controls lung expansion. So your apneistic center is basically, it will take over when you're, let's say if a patient has brain injury, hypoxic brain injury, and the pneumotactic center can't take over, apneistic center takes over and allows you to inspire. So it gives you that long inspiratory breath that if you've seen patients that are apneic with brain injury take that long inspiratory, that would be the what the apneic center would take would do.
Dr. Keisha,
Yes.
you are breaking off, I think.
Oh, sorry. Can you hear me now? Am I audible?
Yes, you're breaking. I don't know if it's my internet or yours, I'm not sure.
Am I breaking?
No, you're fine.
I'm fine, yeah. So basically your apneic center takes a prolonged inspiration, sends signals to the DRG and the VRG, and then allows inspiration. So in your medulla, you have your central chemoreceptors that basically receive stimuli from from different chemicals, your carbon dioxide, your hydrogen ions, and they will sense changes in the CSF pH that will send impulses to the DRG and VRG that will allow for inspiration to occur. So in your basically the dorsal respiratory group is basically the posterior part of your medulla, and your ventral respiratory group has your anterior aspect. So your dorsal respiratory group basically has a nucleus, I think it's the truncus solitarius, that receives different stretch receptors, chemoreceptors, and proprioceptors, and it triggers the diaphragm and intercostal muscles for inspiration. And in your ventral respiratory group, you basically have your Botzinger, your the pre-Botzinger nuclei, the nuclear ambiguous and the nuclear retroambiguous. So all these help in picking up stimuli that will help trigger inspiration. So basically what happens basically, in short, what happens carbon dioxide is our major driver to trigger inspiration when our partial pressures of oxygen are above 60. So basically, you will have carbon dioxide that will diffuse into your brain blood barrier, and of course, carbon dioxide in your CSF, carbon dioxide plus water, you get a bit of carbonic acid, get hydrogen ions that will trigger your central chemoreceptors, and then they will come and trigger send stimuli to the DRG and VRG, and then this will send impulses to the anterior gray horn of your spinal cord, and that will send somatic neurons to C3, C5 that innervate your diaphragm, and T1 to T11 that innervate your intercostal muscles, and then this will aid in the process of inspiration, and then you expire passively. So so I wanted us also to talk about compliance of the lung. Basically, compliance of the lung is basically change in volume per unit change in pressure. So basically, it's just stretchability of the lung. because this will affect your inspiration and expiration. Okay, sorry, will affect your respiration and your breathing basically. So with the 3 factors we have, so with compliance is basically how easy it is for you to stretch the lung. So your change in pressure over a unit change in pressure. So your volume is directly proportional to your compliance, right? And the change in pressure is inversely proportional to your compliance. So you have 3 major factors that affect compliance, where you have elasticity of the lungs. And this basically, when elasticity of a lung is ability of the lung to recoil. So when lungs are very, when lungs have, when lungs are very compliant, they have enough elasticity and it's very easy for them to expand, stroke, recoil. So in example, in a disease like pulmonary fibrosis, where you have scar tissue, your compliance reduces, but your elasticity increases in basically restrictive lung diseases, where you have your, so because of that, there is that because of your increased elasticity, it will be hard for you to expand the lung. That means you will drop so how can I put this in the term? So if you're trying to push air into your lung, it will be hard for it to, for your volume for your lung to expand. And we know that if the volume of the lung remains small, then that means the pressures are high in the lung, and then it will be hard for air to get into the lung. So that makes it hard for the patient to breathe. And yeah, so yes. Well, in COPD patients, let's say, in COPD patients, the reverse occurs. Emphysema, basically, you have breakdown of a lot of elastic tissue. So because of the decrease in elasticity, it's easy for the lung to expand. You have higher compliancy. The lungs are basically floppy, so they can't easily collapse or snap back. So COPD patients with emphysema have very good compliancy, but they have reduced elasticity. So that means it will be hard for air to get out, right? So that's how sometimes they'll end up getting air trapping. So hence they have low forced expiratory volume. So their compliancy increases and their elasticity reduces. So basically, then the second thing that affects compliance is surface tension. And basically, we know surface tension, when you look at the alveoli in the layer, there's water around it. So surface tension basically is that pressure that is formed around that alveoli that causes the lung to collapse. So when you have surfactant that's produced by type 2 alveoli, they will help try and give pressures to help prevent the lung from collapsing in. So that means if you have increased surface tension, you will have reduced lung compliance. And then of course, chest wall elasticity of the chest wall. If your chest wall elasticity is reduced, examples in patients with ankylosing spondylitis and kyphosis, you'll have a reduced compliance. And because they have reduced compliance, then it's hard for the chest wall to expand, and that will also decrease the compliance of the lung, because then it's hard for it to expand. Yeah. So I hope that's fine. So we'll move closely to spirometry. And I just want to talk about your tidal volumes. Okay, let me just, So your tidal volume basically is the amount of volume you breathe in and out. So your tidal volume, this could be your TI inspiration, and this would be your TI expiration. So which basically we know is about 500 mils. So on top of your tidal volume, the maximum amount of volume you can inspire will become your inspiratory reserve volume, which is right here from the tidal volume, right here from the tidal volume up to your maximum capacity, sorry, that you can inspire. And then you have your expiratory reserve volume, where after expiring, your additional, where would be your maximum, where you reach your maximum limit. And then you have your residual volume, which is basically after your first expiratory volume, the amount of volume remains, the minimum amount of volume that remains to prevent the lung from collapsing would be your residual volume. So then we have capacities that just basically, so you have your inspiratory capacity, where you'll have your tidal volume plus your inspiratory reserve volume, which could be the 500 plus your inspiratory reserve volume, which could be if we say this is 500 and this 1,000, 2,000, 3,000, 3,000 plus that would give you about 3,500. And then you have your expiratory capacity, where you have your tidal volume plus your expired reserve volume, which would basically be your 500 plus your expiratory reserve volume here, which is about 2,000 according to this. Yes. Yeah. So would give you, sorry, 1,000, 2,000 minus 1,000, that's 1,000. That would give you 1,500. And then you have your vital capacity, that is the maximum amount of air once you breathe in. So it's your tidal volume plus your inspiratory reserve volume plus your expiratory reserve volume. And then you have your total lung capacity. So this is basically just the total amount your lung volume can hold when you have maximally inspired, maximally expired, and you've considered your residual volume as well. So why is this important? When you are doing pulmonary functional tests, you want to do first spirometry to help you diagnose pulmonary conditions like, let's say if a patient has obstructive pulmonary disease or restrictive pulmonary disease. So you will have a patient connect a spirometer, right? And they will breathe their maximum and have, they will take in a deep breath and then breathe out, expire their maximum amount of volume in the first second, which we usually call as our first expiratory volume, V1 at the 1 second. And then you would have your first vital capacity, which would be your total amount of, your first vital capacity, which would be the highest amount you can inspire and expire. So usually your total is about 0.8, which is about 80%. So with patients with emphysema, you have destruction of of the elasticity of the lung. So you have reduced capability to you have increased compliancy but decreased elasticity. So you have increased volume. So that means your forced expired volume would reduce. So in such patients, you would have and the forced expiratory volume to forced vital capacity ratio less than 80%. While patients with fibrosis, you'll see it will take they have increased elasticity, so they have reduced reduced ability for the lung to expand, thus decreasing your lung compliancy. Hence, they will have a reduced functional vital capacity. Hence, their FEV ratio to FVC ratio would be greater than 80%. Yeah. So yeah, that's all I have for you on mechanics of breathing. Thank you very much.
All right. Thank you very much, Dr. Kemigisha. Do we have any questions? I don't see any questions in the chat, but I certainly do have questions for you. So since there are no questions in the chat, I'll go ahead and launch the poll. The poll has been launched. Please take about 2 minutes to respond to the poll, and then we shall close it at 18:39. All right. So far, 1 minute has been used. There is a question in the chat section, which we shall respond to. Dr. Kemigisha, you respond to that question. Okay, a few more seconds to go, and then we close the poll. All right, in 3, 2, 1, I'll end the poll. Okay, let me share the results. So, Dr. Kemigisha, before you respond to the question in the chat room, do you mind responding to these questions? What is the primary determinant for air resistance? The audience seems to be split between lung compliance and air radius. What's your take? Yes?
Airway radius.
Airway radius. Do you mind explaining why that is the case?
Due to that formula, where you have your resistance equals to radius times length of the tube and surface area. So you have your radius. So it says your radius is directly proportional to your airway resistance. So if your airway resistance, no, sorry, if you're inversely proportional, if your airway resistance is high, if your radius is high, your airway resistance would be low, would reduce, yes. Yeah, that's
Okay.
why I would go with that. Yeah.
Yeah, I think what you're alluding to is Poiseuille's equation or Poiseuille's
Yes, that's
law.
Poiseuille's, yeah, that one.
So if you look up Poiseuille's, the radius is to the power 4. It means that if you just narrow by a centimeter, just by a small fraction, the radius, the resistance is going to increase exponentially to the power 4. So yes, indeed, it's air radius that's most important there. Second question is a patient in the ICU on mechanical ventilation. During assessment, the peak inspiratory pressure is elevated while the plateau pressure remains normal. What is the most likely cause of this finding? 60% of the audience seems to believe it's air resistance due to bronchospasm. What's your take, Dr. Kemigisha?
I agree, it's increased air resistance due to bronchospasm.
All right. And then, okay, do you want to add flesh to what is inspiratory pressure? What's peak inspiratory pressure? How is it different from plateau pressure? And what does that mean in relation to air resistance? Yes, Dr. Kemigisha?
Sorry, you asked what? Sorry.
For the
Peak?
sake of the audience that may not know
Yeah.
the details of mechanical ventilation, what is peak inspiratory pressure, what is plateau pressure, and why is it that when peak inspiratory pressure is elevated and plateau pressure remains normal, we attribute that effect due to airway resistance. Do you mind summarizing that so that we can move to question 3?
Sorry. Your peak inspiratory pressure would be your maximum amount of pressure in your airway, right? In the alveoli. And your P plateau would be the average. Sorry, once you do your inspiratory pause, you get your P plateau. So it would be your amount of pressure in the alveoli. Yes.
Okay, and how is the difference between the two attributed to the resistance?
How is the
How do we attribute the difference between the two to air resistance? Because that is what the question alluded to. Okay, for the sake of time, I think what we have to know is that the peak inspiratory pressure is basically the pressure required to drive oxygen or air, whatever mixture it is, into the alveoli. So it overcomes both resistance and the compliance of the elasticity of the lung to allow inspiration to occur. The plateau pressure is really a static pressure that allows the expansion of the alveoli. So the plateau pressure is related to how compliant the lung actually is, or the chest is, while the is both overcoming resistance and compliance. So if the plateau pressure remains normal, it simply means that the peak pressure going high is due to the resistance. The energy required to overcome that resistance is high. Okay, third question, Dr. Kisha, the hypoxic drive is a myth. Yes, no?
no?
Okay, so I think you may want to add flesh to that, but we're running out of time. I'll leave Dr. Erasmus to
So
respond later. Sorry, I'm not going to let you respond to that. We're running out of time. And then Dr. Erasmus will take that one. And then 60-year-old patient with emphysema has increased lung compliance. Which of the following is a likely clinical consequence of this condition? 75% of the audience says difficulty exhaling due to loss of elastic recoil. Do you agree?
Yes.
Okay, all right. Sorry, I didn't share the results for us to see how the responses were. I just read them out, so apologies for that. So I'll stop sharing. And then, Dr. Rasmus, do you want to take that at the end or do you want to take it now?
No, I can respond so that if we are moving in.
No problem.
Yeah,
Go
so
ahead.
1948, two respiratory therapists found an COPD patient in a crisis. Was hypoxemic as well, administered oxygen, and the patient stopped breathing. They took off oxygen, the patient started breathing. They gave oxygen, the patient stopped breathing again, and they took it off, and the patient started breathing. So they coined the hypoxic drive theory. Their belief was that these patients preferably breathed with low oxygen tension in their body, and giving oxygen to them would knock out their ability to breathe. So that is when the idea of the hypoxic drive started in the 1940s, 1950s, and has still stayed till recently, the 2012 or thereabouts, and people say questioning it because now more data was coming out. So Dr. Shea was supposed to discuss the alveolar equation, the distribution of oxygen across the lungs, and then the arterial oxygen tension and its effect on the pulmonary vasculature, plus the effects of the alveolar oxygen tension on the pulmonary vasculature. The two interact together to determine the distribution of blood flow in the lungs, and therefore the quantity of shunt versus dead space in patients who have deteriorating lung disease. These patients will, when given oxygen, will have a reduction in the hypoxic pulmonary vasoconstriction, which distributes blood across even to the unventilated areas of the lung. Sorry, I hope I'm a bit more audible now. Just into the volume. Yes, so when there is too much distribution of blood across the lung, there will be less elimination of carbon dioxide. So essentially, initially giving store oxygen actually increases the victim mismatch, shunt, and dead space within the lung, which causes them to approach CO2 narcosis quite early, with shutdown of the respiratory drive. And ultimately, take off oxygen that allows the hypoxic pulmonary vasoconstriction to reestablish itself and allows the CO2 to be matched with the ventilation, and they lose the CO2, they wake up and start breathing again. However, the mistake here was that the idea was that if you give oxygen, the people will stop breathing and die. But actually, you need to continue giving them oxygen so that eventually you wash out the carbon dioxide from the lungs and they will be able to breathe again. So it turns out that if you take this patient oxygen or even a higher flow of oxygen, eventually they
Dr. Rasmus, we have lost you. And indeed, the microphone, you sound distant from it. Okay, I think, Dr. Rasmus, we lost you for a bit.
Hello?
We lost you for a bit.
Oh, sorry. I was that hypoxic drive theory, it was based on half-baked observations. It turns out so they avoid going into CO2 narcosis that happens in the oxygenation and oxygen hypertension and circulatory resistance, which causes like failure and early death. Actually, it is more COPD patients, for example, die in their 60s or earlier than that because you don't really protect their heart. They mostly die of heart failure and coronary disease. So it's all based on the hypoxic theory, which taught clinicians to take the COPD, which unfortunately was
All right. Thank you, Dr. Rasmus. I do agree the hypoxic drive is a myth rooted in macro understanding and not the micro understanding of what happens within the lung and the CO2 rise. Okay, I'll share a couple of articles about it on the anesthesia intensive care group for you guys to read. Okay, let's have Kisha please stop sharing, and then we have the last presenter. Because of time, we will not have poll questions for the final presentation. Just go through this, and then in case you have any questions, please feel free to ask. So I will, Kisha, please stop sharing so that, thank you. So I want to invite, I think he dropped off. Nsereko, yes, okay, he's on. Dr. Fred Nsereko to present. Let me make him a co-host. Please go ahead and start your presentation. You'll have not more than 20 minutes. So at 19:12, you should be done. Thank you.
All right, good evening. Dr. Cornell, can you hear me?
Loud and clear.
All right. All right, so we're going to talk about respiratory support and physiology of mechanical ventilation. I am Fred Nsereko. The outline, there are some key terms that have already been really highlighted by the previous speakers. We'll talk about a brief respiratory failure, respiratory support, and then the main talk will be about the interplay of the physiology between mechanical ventilation and the different organ systems. So these are terms that will probably show up a lot more in the talk, but they've already been covered. We have the tidal volume, the minute ventilation, dead space, shunt, the PEEP, and the partial pressure of oxygen in arterial blood, or the PaO2. Again, just a recap about shunt and dead space that I think has been well understood. The waist lung zones, I wanted to just reiterate that depending on your positioning, whether you're lying supine or you're standing up, the waist lung zones redistribute accordingly. Even when you're having a patient lying to their side, the dependent lung becomes zone 1, and so forth and so forth. So the waist lung zones differ, and that is probably the rationale for why proning also helps. It's important to talk about hypoxia again, although it was covered. Most of the time when we are intervening, we are thinking about hypoxia, but it's important to always know that there are other mechanisms that could be at play that influence whether your mechanical ventilation will be very useful or if you need to do something different. For instance, if someone is anemic, despite you flooding them with oxygen, they don't have the oxygen carrying capacity that they require, or if they're chronic smoker, or if they've been in a burning building, they might have high levels of carbon monoxide that take up this hemoglobin so that less oxygen is able to bind with the sites on the hemoglobin. The patients may also have circulatory issues, which are common in the ICU because they typically have shock states. If you don't intervene on the shock side of things to improve the circulation, your mechanical ventilation will not help, and in fact, as we shall see, may be dangerous. Certain chemicals like cyanide can interfere with the body's ability to utilize oxygen, despite the fact that you provide all the oxygen in the world. So respiratory failure refers to a deficiency for the gas exchange to meet the metabolic demand of the body. And in practical terms, we use cutoffs of arterial partial pressure of oxygen less than 60 and partial pressure of carbon dioxide above 45, some references quote 50, or both. as you'll note, most of these things are not absolute. There is always an intermix of the different types. So we have types like the acute hypoxemic, which typically results from VQ mismatch and shunt, like Dr. Shaif pointed out. We have the hypercapnic, which typically comes up as a result of alveolar hyperventilation. This could be because you're paralyzed or you've taken drugs like morphine that blunt the respiratory drive. Then we have the perioperative respiratory failure, which commonly occurs because of issues of positioning and the lung collapses, issues of too much fluid administered at the operating table. There could be also other things at play, like for instance, if you use sedatives, if you use neuromuscular blockers, and these could all combine to give you a mixed picture of the different types of respiratory failure. There is also shock, where you might find there is very little blood returning to the heart to be oxygenated. So you will be having a respiratory failure because of low return, and the muscles of respiration themselves will be fatigued because they're not receiving the adequate blood supply. So respiratory support refers to any interventions we put in place to try to assist a person who is spontaneously breathing, or in the last resort, to replace the spontaneous breathing. So it begins with oxygen therapy that you could administer via a simple nasal prongs. You could use a face mask. You could use a nano-breather mask. You could use high flow nasal oxygen. Now, for this session, we shan't go into the specifics of this. I'm hoping we shall have a different session to try to rationalize why we have all these modalities. But it's important to know the flow rates that go with each of these modalities. Then we have non-invasive ventilation, which is a bit more advanced support. And this can be in the form of CPAP or BiPAP. CPAP is continuous positive airway pressure. This means that you give a patient using a mask or a helmet, you give a patient a continuous positive pressure via machine during both breathing in and breathing out. This helps to maintain the alveolar open and decrease the work of breathing. It's commonly used for people who have obstructive sleep apnea, people who have COPD exacerbations. You could use this to try and help them out. BiPAP is simply CPAP, but now we vary the pressures depending on whether the patient is breathing in or breathing out. The way it's administered is a bit the same, and with also a machine. The QRS is an adaptation of an archaic modality we used to have called the iron lung, where a patient would be put in a sort of cylindrical body. The entire body is in there, and then this cylinder creates negative pressure around the chest and helps the patient take in air. And then when it releases, the chest recoil comes back and sends out the air. The patient expires. So the QRS is a modern adaptation of that. We shall see what that looks like. Mechanical ventilation, by this we mean invasive mechanical ventilation, is the other modality, and it's the main topic of our talk. There are also other advanced things like the extracorporeal membrane oxygenation. If all these things are failing and you're in a good center, in Uganda, the only center we have capable of doing this is the Uganda Heart Institute. We could use the heart-lung machines to administer this, but you could use other modalities like ECMO to oxygenate the blood outside of the body while you buy time for whatever is hurting the lungs to resolve, and then the patient can breathe again on their own. The other adjunctive things that we can do to support the respiration, like for instance, prone positioning. We already said we can use the physiology of waist zones to rationalize why proning would help a patient out. If you've kept a patient supine for a long time, you're going to have collapse and gravitation of fluid to those posterior segments, such that when you turn the patient around, you will have an improvement in the overall oxygenation, because blood flow will gravitate towards now the dorsal side of the chest, and it will be better matched with the ventilation. We have sedation and paralysis. These are usually required for patients who have severe ARDS and are not synchronizing with the machines. You might have to sedate them so that you avoid lung injury. Then we have pulmonary physiotherapy. We have patients whose lungs have collapsed. You can do postural drainage using physiotherapy to reopen the airways. You can use vibrations applied to the chest to break up the mucus that's plugging the airways, and that could help the patient's breathing improve, even without doing anything else besides, say, giving some oxygen via nasal prongs. These are just images. We have the high flow. A here is a patient on high flow nasal oxygen. You can see it's a setup. It has a humidifier. It can give you oxygen at very high flows, 60 liters per minute and above. And this enables the patient to be able to communicate. It's not as bulky as a CPAP mask. You can see the CPAP mask at D. It doesn't enable the patient to like drink. It's more bulky. The high flow nasal oxygen is a better system in that regard. We have these systems in the ICU. They were used a lot in the COVID times. If you want to have a look at them, they are available. Then image C is what an ECMO machine would look like. But if you want to have a look at something close, you can go to the Heart Institute and see the heart-lung machines there. They kind of do this as well. Then in B, we have the QRS. You can see there is a device that is attached to the chest to create a good seal. And then that device sucks up air, creates a negative suction, which makes the chest expand, and air is drawn in. And then when it releases, the elastic recoil sends the air out. This is typically used for patients with neuromuscular diseases who are going to need support in the long term. So we come down to mechanical ventilation. What do we mean by invasive mechanical ventilation? It means we connect a ventilator through a tube. This could be a tracheostomy tube or an endotracheal tube to the upper airway, and the lungs are inflated using positive pressure. This slightly differs because normally we breathe at negative pressure to inflate the lungs, but this is positive pressure. Then we have two types. There is the conventional, then there is the high flow oscillatory ventilation, which we do not have here. And also the literature doesn't say that one is very superior to the other. However, high flow oscillatory ventilation can be used when airway pressures are very high and you want to avoid causing lung injury because of that. Then again, we have the non-invasive mechanical ventilation. You could support ventilation, like when you do bag masking with just a mask, you're actually supporting ventilation via NIV, although it is a transient thing. Then you could use CPAP, you could use BiPAP and the QRS. The indications for invasive mechanical ventilation for a patient who is getting exhausted. Sometimes the patient's ABG is still compensating, it's still looking good, but you realize the work of breathing will definitely lead them to get exhausted. And also the respiratory muscles are working overdrive, consuming the very same oxygen the patient is struggling to get into the body. So you need them to rest the muscles. So you intubate them and put them on a ventilator. Patients with neuromuscular weakness, like patients who get Guillain-Barré syndrome, you've seen some of them in the ICU. We need to support their breathing, or patients who have suffered cervical spine injuries. Patients who have been medicated, let's say a patient is going for a cesarean section and then someone gives them, while they're on table, they complain of pain, someone gives them an opioid, and then their breathing starts to fail. You need to support. So that's why you have to prepare for both intubation and then your spinal in a situation like that. We have hypoxemia. This could be because of shunts, like Dr. Shaif already discussed, pneumonia, ARDS. All of those are indications for mechanical ventilation. And then airway protection. Sometimes we have patients who are just unconscious. It could be because of intoxication. It could be because of head injury. It could be because they're undergoing surgery in the abdomen, and the risk of airway soiling is very high. So you intubate them and ventilate them just because you need to protect the airway from being soiled by GI content in the event they vomit. So we have gas flow mechanisms. Dr. Sophia had pointed out some of it in a sort of nutshell. But to be more specific, in the larger airways, there is turbulent flow. In the smaller airways, medium-sized airways, there is less turbulence, there is more laminar flow. air usually travels by mass flow, by bulk flow in these airways, and via a process of convection where the dense fresh air flows down and displaces the warm exhaust air, which is sent out. But as you can see, while this air is coming out, not all the alveolar spaces are going to be draining out at the same time. So there will be different velocities of, say, air coming out while there is some air trying to go in. So there will be a differential inflation of these units. After all of that has happened, there is what we call the pendeluft, which means that air at the end of, let's say, an inspiration is going to redistribute from one alveolar unit to the other. That is also one way that air moves. And then finally, we have diffusion of gases out of the alveolar sacs into blood and vice versa. So we're talking about, in the previous talk, we were talking about inspiratory holds, peak inspiratory pressures. So we shall probably at some point talk about ventilator waveforms and such other things. But as a basic introduction, these are very common waveforms. You can see up there, we have a pressure time curve. You can see, let me try to get the pointer. Pointer.
You can use the cursor on this.
Okay, it's fine. I think you can see, I don't think I've chosen the right tool, but it's fine. I think you can see my cursor on the screen. Up here, we have the pressure time curve. And you can see when the pressure rises, this is now positive pressure. The vent is sending in air. It gets to a peak, the maximum pressure at which you would have set. Let's say you're doing pressure supported ventilation. We'll come to what these terms mean in the subsequent talks. And then at that point, the ventilator will release, and then there is distribution of gas, because this peak airway pressure is just gas flowing through the bigger airways. That is what it detects. Now, once gas has gone into the lung, it redistributes. So when you do an inspiratory hold, what happens is, based on the gas flow that I just showed in the previous segment, the gas redistributes evenly across the alveolar units, and then you will have a drop-off because of that redistribution. And that drop-off, where it stops, you have your peak plateau pressure. And the relevance of this is that this first one, the peak airway pressure, is going to tell you about resistance in the airways, because we are picking it up the maximum pressure when there is maximum flow in the airways. And then subsequently, you will have redistribution. This one will tell you about the compliance of the lungs, because the air is redistributing across the alveolar sacs. And then finally, you have the deflation, because the positive pressure stops and the vent cycles over into expiration. So the pressures fall. And the baseline between the point 0 and where the fall off stops is the PEEP that you would have set. If you've set a PEEP of 8, it means this curve will fall back to 8. If you've set 5, like typically happens, it will have fallen back to a 5. So the next one is a flow volume curve. Depending on what you've set, because the modern ventilators have different ways this can be administered, but this is telling us that you're going to send in flow all at once. Normally we breathe in a decelerating pattern, meaning that we start off by taking a lot, and then as you breathe in further, the flow starts to decelerate. But here we are seeing the flow going in once, and then once it reaches a certain set point, the ventilator stops, and then you start cycling back to. The flow will reach the maximum flow rate, and at that point, flow will start to stop. So this is flow has stopped. And then when flow stops, it starts to go back to negative and you cycle back to expiration. In expiration, flow increases in the negative sense, but because expiration is passive, we shall not have the same shape. Expression is passive. If we had set a decelerating pattern here, you would have had a curve that is lopsided like this one, but in the positive sense. So here we shall have the elastic recoil of the chest aiding the flow. So flow will be in a decelerating pattern. That is what that indicates. And then you can have a volume time curve still. If you've set a volume, what will happen is the vent sends in this volume. At some point, it reaches the volume you've set, and then it recycles back into expiration. The chest recoils, and air is sent out. And the reason it is still lopsided like that is because it is elastic recoil that is helping you send out this volume, and it is in a decelerating pattern. So that's a basic interpretation of waveforms, but we shall talk about more of those as we have more of these sessions. All right. So we go to the main part of the talk. That was all introduction. The physiological effects of mechanical ventilation vary per system. We will start with the main system of interest, which is the respiratory system. When you administer positive pressure, what will happen is when the lung, when the airways and the lung expand, the volume of these conducting airways, the ones that we're saying from the generations that are just conducting airways, their volume increases. Just imagine like inflating a bouncing castle from a collapsed state to a full castle. Now, those airways are going to contain a bigger volume. So you increase the dead space, and that dead space we're talking about then is an atomic dead space because it's comprised in those airways. The downside of this is that when you've inflated these alveoli, the capillaries that pass in between these alveoli, if the pressures are so high, can actually collapse because the distending capillaries occlude blood flow through these capillaries. And then what you will have is you'll be ventilating a capillary unit with a lot of air, but there will be no blood flow going across. And then that means the alveolar dead space will be increasing. That is one effect of ventilation. And you might notice after you've just intubated a patient and connected them to a ventilator that the partial pressure carbon dioxide increases. This is why at the start, people tend to send a fairly high respiratory rate. Now, a fairly high respiratory rate would correct for this rising partial pressure carbon dioxide. But it's important to also know this concept of auto PEEP, meaning that the higher the auto PEEP simply means that if you send in 500 mils of air at exhalation, if you don't leave enough time to pass, you will have maybe 300 mils coming out. And on the next breath, maybe 200 mils coming out. So there is a deficit of air that isn't coming out of the patient's chest. And what happens is the lungs over-distend. There is trapped gas. And of course, that will worsen the alveolar dead space and predispose you to things like barotrauma of these alveolar units. So you'll notice that there is a cap on the respiratory rate by virtue of the fact that the higher the respiratory rate, the less there is time for the lungs to exhale. And that means the auto PEEP is likely to go up. In terms of other effects, as you are ventilating this patient, there is a risk that you are going to distend these alveoli and capillary walls, and you will have what we call ventilator-induced lung injury, which is very dangerous because it releases a lot of cytokines, and sometimes someone who starts off with just a lobar pneumonia then ends up with all the lungs damaged. So we'll talk about that more. Here is a picture that I got from West, demonstrating what can happen to the alveoli. All right, so you can see the alveoli, and you can see blood flow through the capillaries what you're seeing, the dark lines are red blood cells. Now, when you apply the positive pressure ventilation, what will happen is the capillaries are crushed while the alveoli distend. This is just demonstrating the same thing we're talking about, that applying this positive pressure can be dangerous in that sense. Furthermore, as we play around with our fraction of inspired oxygen, it's important to remember that normally we just need around 60 to 100 milligrams of mercury of partial pressure of oxygen in the arteries to oxygenate very well. So when your FiO2 is giving something higher than that, there is a risk of oxygen toxicity, which is reactive oxygen species that could damage cells. You also have, there have been experiments where people have been given high doses of oxygen for a while, and over like 24 hours, some people develop edema, pulmonary edema, some people develop retrosternal chest pain, although most of the studies on oxygen toxicity are based on animals and not on human beings. There is a risk of absorption atelectasis because remember, oxygen is absorbed by the blood. Normally, when we breathe 21%, it means we are taking in 78% nitrogen alongside, and nitrogen is not very soluble. It's not readily taken up, so it kind of contributes to a fraction of air that keeps the airways open. When you take 100% oxygen, you wash out all this nitrogen, and what will happen is, if the unit, the alveolar unit, is occluded for some reason, all the oxygen that is contained within easily diffuses over into the blood, and then this unit is going to collapse. That is what absorption atelectasis means. Also, as we've already said, when you have a shunt, a large shunt, let's say you have a very bad pneumonia, or you have ARDS or pulmonary edema, the high fraction of inspired oxygen may not improve the oxygenation, never mind the hypoxic pulmonary vascular constriction, because this shunt is very large. What will happen is we use the positive end expiratory pressure, or the PEEP, to recruit these alveoli. So just imagine there is alveoli that have collapsed. What you do is you intubate the patient, you subject them to positive airway pressure, and this will open up these airways, and you apply a PEEP so that at the end of exhalation, these airways that were difficult to open up do not fully empty out, so that they're easier to inflate on the subsequent breaths. And by doing so, you reduce on the shunt, because now some of these alveolar units that had collapsed and still have blood flow through them, the blood flowing through them will actually get some oxygenation coming in. The other effect is that when patients are connected to ventilators, we use high gas flow rates, and these medical gases are usually cold and they are dry, they don't have any moisture in them. Normally, our upper airways are able to humidify all the gas that we breathe in, such that it's 100% saturated with water vapor by the time it gets to the lungs. However, when we're sending in dry medical gases into patients, they are not appropriately humidified. Commonly, we use HME filters, which do not give as much humidification as what the physiological setup does for us. So these cold gases, they thicken the mucus so that patients often have mucus plugs, and then they impair the functioning of cilia. Remember, the cilia are supposed to beat and move mucus along the respiratory tracts to prevent blockage. And they also dry up the epithelium, which is likely to crack and get damaged. And this sloughing of the epithelium, the impaired ciliary movement, they predispose to secretions that clog up these airways, and they are likely to cause atelectasis, like we previously said, and then predispose you to infections. The loss of air reflexes results in a pooling of secretions, because when you put a tube into the patient, very often you have to sedate them. The sedation, alongside the fact that you're ventilating them, abolishes their cough reflex. And the secretions that ideally are cleared by the cough reflex start pooling, and they are rich in protein and all manner of culture medium for bacteria that could come from your oral cavity, trickle down the ETT all the way into the lungs and set up an infection. Very often we need to also sedate the patients. We need to sedate the patients and blunt out their respiratory drive so that they can breathe better on the ventilator. this is now applying the physiology of how drugs affect the control of breathing. Oh, nearly out of time. Okay, 5 minutes. So this is a graph to show how the lung. This is a graph to show how the lung and pulmonary vascular resistance, how lung volume and pulmonary vascular resistance interplay. You will notice that at functional residual capacity, you have the maximum benefit. So if you're able to recruit the lung to okay. So if you're able to recruit the lung to get it back to just the functional residual capacity, that is where the maximum benefit lies. So initially, the hypoxic pulmonary vascular occlusion helps to. So when you have the lung collapsed, the pulmonary vascular constriction is also high. But when you start to re-expand the lung, what will happen is initially, as you can see on the key, the extra alveolar vessels, they start to distend because they distend with the major airways. They start to distend and their volume increases. Remember what we were saying about the dead space? That's how their volume increases. And that increment starts to fall with time. Now, for the intra-alveolar vessels, when you inflate the lung, what will happen is initially they are splinted open. They're splinted open, and resistance then would not be so much of a big problem, especially when we are talking about lung volume that equates the functional residual capacity, which is in adult is around 3 liters. Now, as you continue to distend the lung, what will happen is the vascular resistance in the intra-alveolar vessels starts to increase because now the distending alveolar units are pressing against the capillaries, such that you will have an increase in pulmonary vascular resistance. And this curve here shows the total pulmonary vascular resistance as a product of both of these processes. So you'll have your pulmonary vascular resistance falling, then at FRC, that's the maximum benefit, then it starts to go away because the pulmonary vascular resistance starts to increase. Okay. So in terms of the cardiovascular effects, we've already seen one. That would mean that the right ventricular afterload increases because the pulmonary vascular resistance increases. The work that the right side of the heart has to do to overcome that resistance increases, and that can predispose you to right ventricular dysfunction. The positive pressure in the chest impedes venous return. Remember, central venous pressure is supposed to be lower than all the pressures in the different venous beds for blood to be flowing back to the chest. But when we add positive pressure to the chest, especially in situations where we have hypovolemia, the cardiac output suffers. That's why when we intubate patients, typically the blood pressure may fall if the patients are not well resuscitated, or they may actually suffer an immediate cardiac arrest because of that fall in cardiac output. And also, you might find that your ABG is showing you that the partial pressure of arterial oxygen has improved, but actually the amount of blood leaving the heart is much less, such that you might have a glass full of 100% oxygen, but that is not more oxygen than, say, a Benson full of 60% oxygen. So you start to think about the partial pressure of oxygen versus the total arterial blood content of the oxygen. Because people in, like in Peru, there have been some studies that were done for people who live in very mountainous areas. Like in Peru, they can actually have 80% oxygen saturation, but it is physiological for them. The reason they have that is because they have a larger white red cell mass, and they have the appropriate oxygen content that can sustain the body. Although the saturation per unit of blood will probably be less. Also, another implication is that when you're having positive pressure ventilation, you're not able to use.
Good.
Yes, Dr.
Could you
Kunil.
wrap up in 2 minutes? You've far
Absolutely.
extended.
Yeah. So the central venous pressure that typically we use to assess volume status in some situations can be useful. When you're doing positive pressure ventilation, that one is out because the positive pressure itself will raise the central venous pressure. Then in terms of hematology, When the ventilator causes ventilator-induced lung injury, there will be release of cytokines, and these influence the immune system and its functioning. They can cause body-wide inflammation. And this inflammation and the cytokine release can cause changes in the vascular beds in terms of how things are flowing. They can also hurt the endothelium of vessels, predisposing you to thrombosis and disseminated intravascular coagulation. When you hyperventilate the body, you blow off a lot of CO2. And when the CO2 is low, the oxygen dissociation curve shifts to the left, meaning whereas there's oxygen loading, the hemoglobin doesn't really give off this oxygen. So you might find both the arterial and venous oxygens being quite high. In terms of the CNS, positive pressure will reduce the drainage from the brain, putting a back pressure on the brain, which is likely to cause raised ICP. And then because of the decrease in cardiac output, you will have a fall in the cerebral perfusion pressure as the map also drops. In severe ARDS, you have to remember that the patient, when you're paralyzing them, if they are aware you're going to cause a lot of distress, so you have to use neuromuscular blockers with sedative agents. Some drug metabolites like midazolam predispose people to ICU delirium after ventilation. In terms of the gastrointestinal system, we always use GI prophylaxis for patients who are not feeding, because positive pressure ventilation creates a back pressure in the GI beds. It also causes a reduction in cardiac output, and all these things could cause the GI to malfunction. We have drugs that we give during positive pressure ventilation, like opiates and benzodiazepines, that reduce the GI motility and cause venodilation in the GI beds. Then for the renal, the same thing happens. If the cardiac output falls, you'll have decreased renal perfusion pressure, predisposing you to AKI. And then the cytokines from ventilator-induced lung injury can also cause injury in the kidneys. There will be a retention of sodium and water as a result of activation of the sympathetic system and the renin-angiotensin system. Obviously, when you're ventilating a patient, you're blowing off a lot of CO2, which plays into the acid-base balance of the body. In conclusion, mechanical ventilation is a good tool to use, but it is a double-edged sword. It's important to know the merits and demerits and apply careful decision-making to each individual patient while using it. Thank you very much.
All right, thank you very much, Dr. Nsereko. I think that was quite elaborate and summing up all the previous talks into the clinical applicability at the bedside using a mechanical ventilator. All right, I will invite Dr. Erasmus, the mentor, to give a wrap up on this and then also close the session, hopefully in the next 10 minutes. Over to you, Dr. Erasmus. Is Dr. Erasmus online? I'm not seeing him. Okay, he's online. Dr. Erasmus, you're still muted in case you didn't know.
Yes, thank you. Kindly retire the slides, please. Why so? Sorry, I'm afraid. Okay, here we go. All right, good evening. Thank you so much for the talks. And unlike the previous time we're doing these talks, we are trying our best to contract the sessions to a maximum of 2 hours. And already 30 minutes past that mark, but good enough for a start. Thank you, Dr. Cornelius, for moderating this, and thank you so much, Dr. Namuviru, Dr. Semakula, Dr. Skemigisha, and Dr. Nsereko for elaborately introducing us to pulmonary madness. We started this out with the lung in motion, talking about the physiology of a breathing lung, and the objective was to help us understand the physiological basis of breathing in health and mechanical ventilation. The team has definitely taken us through a number of things, and really my goal here is to highlight that normal and abnormal physiology tend to interact together in lung disease. Generally, diseased lung stops functioning and the patient is surviving on the normal lung and recruiting more of the normal lung try to survive. And then, and that really is a balance that you need to understand. And you can only help these patients if you will know physiology. Similarly, normal physiology is essentially the unsuspecting victim in respiratory support. Every intervention we do to help patients is really going to affect the normal physiology of that lung, normal physiology of the cardiovascular system and other things. And the damaged part already is in hibernation or irreversibly damaged. And you hope to hold on to the normal physiology in this patient to keep them alive. Unfortunately, most of the interventions we provide in medicine, especially in critical care and respiratory support, all affect the normal physiology. Ventilation, as Dr. Nsereko has just told us, talk about oxygen therapies, which can affect the distribution of blood flow and other things and mess up the patient or improve the patient. Talking about the distant effects beyond the lung and cardiovascular system that can happen from all the respiratory support interventions. So again, thou shalt know physiology so that you can actually hold that normal physiology well enough to save a life. Remember that normal physiology is a real avenger. It is the one thing that holds the patient alive and potentially allows the patient to recover from what they have gone through. And again, in all this respiratory support, you are trying to optimize that normal physiology, to optimize gas exchange and keep the patient alive. Again, remember normal physiology. And for sure, remember normal physiology. I'm not going to add too much to this because the team has already given us the physiology. Kindly review that a lot more and understand more. Next week, we shall be going into the pathophysiology side of things and seeing what we can do about it. In particular, we shall be tackling hypoxemic respiratory failure, probably the most common organ system dysfunction in the hospital. And the one thing that also is very abused in terms of interventions and wasted of resources goes into the care of patients who have got respiratory issues. We shall communicate a date, be prepared, review the subject, and be present on that date with helpful questions so that we can beef up the communication. So this has resumed. We have laid the foundation stone and we are ready to take off and probably never stop. So thank you so much, everybody, for participating. Thank you to the presenters. I see a question on the chat before I close. Dr. Conlon, I'll take just a minute on that. So Dr. Semakula is asking a clarification, please. Does mechanical ventilation improve output of the left side of the heart, hence improve cardiac output? And Ignatius answers, if the right side didn't get enough return, where will the left get blood? So I'm going to assign this to this particular aspect to go and review the effects on the preload and afterload and the transmural pressures of the heart from mechanical ventilation, and then see what the answer will look like. So thank you very much. I hope this was helpful, but I hope that whatever we've discussed today will be very helpful to us in understanding the future topics we shall handle. And for now, thank you and good night. Bye-bye.
All right. Goodbye, everyone, and have a nice weekend.